say a few background words about Leo. I remember my strongest memory of Leo is a water polo game we had during the summer of 1966, where I broke Leo's eardrum. Leo came to EIS, and he was one of those statistical people, one of those people that knows numbers, and he was involved with DA and others in the initial planning of the smallpox measles program. And then he happened to go to Brazil to test the feasibility and efficacy of smallpox vaccine with the jet injector, and eventually was sent there as part of the WHO program to take care of smallpox in Brazil, which was the only place left in the Western Hemisphere. It's a great pleasure that I introduce Dr. Leo Marvin.
Thank you, Stan. You'll hear mostly about West Africa today, but CDC did have a presence in Brazil. The presence was me. I was fortunate enough to be among the original 8 persons that organizationally started the Smallpox Eradication Program as it broke out of the surveillance section of the old Bureau of Epidemiology. Helped recruit and train the first group at 66 that went to West Africa. And then PAHO, the Regional Office of the Americas for the World Health Organization, came to CDC and wanted a statistical consultant for their eradication program in Brazil. Stan mentioned it was the only country with endemic smallpox in this hemisphere. And I had been in Brazil in smallpox vaccine trials with Don Millar and Tom Mack in '65, and fell in love with the country and determined that, well, I have to go back and learn how to samba. But I volunteered for that, and I was together with a 4-person team, 3 physicians, one the team leader from Peru, another from Paraguay, and from Colombia. This is a map of Brazil showing the 27 federation units, states. At that time there were some territories. I just want to point out on the east coast, Alagoas, the small state underneath Pernambuco, because I'll be mentioning that. And all I have to do is go down, right? There we go. We got to Brazil in March 1967. We weren't there for Carnival. Carnival had just finished, and people were sort of coming back to work very slowly. But there were 2 priorities in this new smallpox office in the Ministry of Health in Brazil. Was mass vaccination, as was the WHO line at that time, and to improve the reporting system. In 1966, they didn't even know how many states or federation units were reporting. They had reported about 3,623 cases, of which only 43% had the age and sex, and the onset of disease was better reported. So one of the first issues was to create a reporting system and better surveillance. Federation units reporting in '67 was 19. This took a lot of visits to the state health departments. They have a state health system like in the U.S., unlike the other Latin American countries where it's federal down to the lowest level. Mexico has states, but they're not as autonomous as in Brazil. About 57% had better reporting on age and sex. 68, we had 23 states, and a few less cases reporting. We found out later this was mostly underreporting. 70% reporting in the surveillance system, age and sex. Then in '69, it went up to 7,407 due to better reporting. There wasn't increase in real cases, but this was a bit difficult to explain to the press. One manner of trying to explain it to the press was that in the 12 states of the Northeast, the program began in the Northeast, the poorest areas in Brazil, 12 federation units, There was between 68 and 69 an 80% drop in cases, and in the 13 mostly southern states, a 99% increase as reporting became better. And in these states, the program was beginning in late 68 and 69. From the beginning, I was trying to establish, as we trained the people going to West Africa, the idea of evaluation units, monitoring, mainly through sample survey, population-based sample surveys, which was, I know, less known in West Africa, but still not very widely used in Latin America at that time. And in June, July, I mentioned that state, Alagoas. There's a county called Branquinhas, about an hour and a half by train off the coast. And in June, July, and I was trying to convince them, we had to train evaluators, we had to monitor not only cases being reported, but how well the vaccination program was going. And these evaluation surveys consisted of percent of total population being vaccinated and looking at take rates in kids under 5. And the evaluation teams came 7 to 10 days later after the vaccination teams. In June, July, in 67, there was a notification of 51 cases of smallpox, an outbreak in Branquinhas. We went back to look at the records. This is one of the first states with mass vaccination, and 104% of the estimated population was reported to be vaccinated. This is the same problem mentioned by Stan. They vaccinated schools twice. They had estimated populations. So many times more people were reported about being vaccinated than... And this was our first epidemic aid. I went up with 2 counterparts to do an epidemic investigation, but first the diagnosis was confirmed in the laboratory. It wasn't chickenpox, it was smallpox. The survey gathered data to show that first the vaccine used there produced satisfactory take rates. We looked at maybe this was a migration of people from other areas into Branquinhas in the last 4 months, but that wasn't true. That all of the cases were long-term residents, and the survey showed that in reality only 49% of residents had been vaccinated. This was sort of egg in the face of the campaign officials and convinced them, yes, we need evaluation. The records were falsified, in other words, by the team. They were fired. The state director was reprimanded, and this led to the implementation of the evaluation teams. Then, in late 1968, as surveillance containment became more of the attack phase of the program, we organized an EIS-type course for the state program directors, and a bunch of newly recruited young MDs out of medical school are recently working in a special public health service for surveillance containment units, mainly in the big populated states of in the south where the campaign was moving in late 68 and 69, Bahia, Minas Gerais, Rio de Janeiro, Paraná, and Rio Grande do Sul. There was a lot of interaction in Sao Paulo state, the largest state, but they did not take federal employees, only state employees. They accepted the vaccine and the vehicles and jet injectors, but they didn't want any federal employees in the state. In 1969, these surveillance containment units investigated 33 reported outbreaks that initiated from 27 cases. More outbreaks because sometimes one investigation of an outbreak led to where it was imported from. And these investigations yielded 1,465 cases. And this suggested that reporting was only about 2% in endemic areas. Brazil had variola minor, a much lower case fatality rate, 0.8% in these outbreaks. Most deaths, almost all, were among pregnant women or infants. The attack rate for unvaccinated persons was 76% in these outbreaks, and vaccinated persons 3%. But this initiated the activity of the surveillance containment units, which started, although there was still some mass vaccination going on, towards this new epidemiologic tool. I want to talk a little bit about post-program contributions. The last case in Brazil was in January, February 1971. But perhaps per capita, the people trained in Brazil maybe contributed, except for CDC, most of any other country to the programs in other parts of the world. Eduardo de Azevedo Costa, who was assigned to Bahia, he became the director of the epidemiology department of the School of Public Health in Rio de Janeiro and later the state health officer. Advanced epidemiology to a great deal higher level in Brazil. Milton Arndt, I think Stan ran across, he was in Bangladesh, wasn't he? Yes, he was. Yep. He became a smallpox advisor. He was in the state of Minas Gerais. He became a smallpox advisor in Bangladesh and later the PAHO country office head in Argentina. João Rizzi, who I was in Brasilia about 2.5 years ago and met once again. He became the national director of the immunization program in the Ministry of Health. And I might say he continued, we developed a smallpox eradication monthly report based on the new reporting system. And at the end of the smallpox eradication program, this was sort of expanded into a MMWR type report for about 8 other infectious diseases, principally the ones that you could immunize against. And he was very instrumental in that. And when I met him in Brasilia a couple of years ago, he was in the country office of PAHO in Brasilia. Ciro de Quadros, who many of you know, became the WHO smallpox advisor in Ethiopia. I don't know if he went elsewhere, but then later became director of immunization programs for PAHO in the Americas. I know he received some kind of award from the King of Thailand, which is not in Latin America, but he received this award. And he was one of our most enthusiastic surveillance containment people in the state of Paraná, in southern Brazil. And then the state of Rio Grande do Sul in the south, Clovis Tigre, who had one of the best state health departments. He became an epidemiologist in PAHO in Washington. Claudio Amaral, he was smallpox advisor in India for WHO after the Brazilian program. And Ayrton Fisherman became the state epidemiologist in Rio Grande do Sul. To mention one other program, contributions, which involved a completely different program at CDC. When I returned from Brazil, and after going back to school for 2 years, I joined the new, what is now the Division of Reproductive Health at CDC, and spent my last, 72 to retirement in 2004 in the Division of Reproductive Health. And had a program with AID USA to assist family planning maternal child health programs in developing countries. And we introduced the concept right away of population-based surveys to monitor and evaluate programs. And some people in states were left over from the smallpox program. They were more readily eager to do this. And from 78 to 82, we assisted with 11 statewide maternal child health family planning surveys. In 86 and 96, 2 national maternal child health and family planning surveys. From 87 to 1990, 5 urban young adult reproductive health surveys went more into sexual behavior, beyond just family planning, because they're concentrated more on unmarried people rather than the married. And then in another area, with the Foreign Epidemiology Training Program in Brazil, it was in its 4th year, and they wanted to expand somewhat from infectious diseases to other areas. And we have this manual and epidemiology applied to reproductive health workshop, since been translated to Spanish. I with a colleague in Brazil to Portuguese, it's in Chinese, we have a draft in Romanian, and they asked us to do the workshop in epidemiology applied to reproductive health, which has a heavy content, again, on population-based surveys. So this is just a small glimpse. I could tell you much more, but of our participation in Brazil, how the surveillance containment strategy was transferred from West Africa, and how I feel a lot of Brazilians have then contributed immensely to the WHO programs in other parts of the world. Thank you.